What is this case? Which year is this?
Okay,
And what
so
is your
now
plan? What is your plan?
This is a right-sided otosclerosis. It's a bilateral otosclerosis case. She is a 37-year-old lady and she has high-frequency sensory neural hearing loss. So in this kind of a case, I'm anticipating some degree of thickened foot plate, probably some degree of active focus like Ashish experienced a while ago. Now, when we opened her, this is a standard endometrial incision but we always take an anterior limb which is slightly more extended for the endometrial incision so that we can see at the end of the day the anterior malleol ligament also. In many cases of long-standing otosclerosis and long-standing ossicular issues, you find a hyalinization of the anterior malleol ligament. And sometimes where we have a habit of doing intraoperative audiometry. And during the intraoperative audiometry, we have seen actually a jump of 5 or 10 decibels once we divide the anterior malleol ligament. Yeah, Ravi.
In technique or anything, once you have a associated high frequency bone conduction loss?
See, one thing is for sure, that I will anticipate in a slight ossification, additional ossification and slight active focus of otosclerosis in such a case. I'm very sure to anticipate. She's a young lady and still with such a high degree of sensory neural loss means that there might be an obliterative focus. If there is an obliterative focus, then I will not do a vein interposition, I will do a direct piston.
Of large fenestra, partial stapedotomy, or large piston, or anything.
My concept is that there have been many studies, including the latest one by Janka, that the larger the fenestra, the better the hearing post-op. We are talking about a large fenestra. We are not talking of stapedectomy. Large fenestra means it is the fenestra is surrounded by the footplate on all sides in 360 degrees.
Stapedotomy.
Not partial stapedectomy. So the problem with partial stapedectomy is that the additional trauma of dislocating the posterior fragment or most of the footplate from the stapediovestibular ligament, it's very risky for the sensory neural hearing loss. So although you will get a very good closure of the lower frequencies, the higher frequencies you'll end up with higher degree of sensory neural loss, and therefore you will be stuck in a scenario where you will have better hearing but poorer discrimination. Because for me, discrimination is a more important indicator than hearing alone. Any problems?
Okay. Great, boss. And I congratulate you for the very good picture we are getting.
Yes, wonderful.
Amazing picture.
Thank you.
How do you use this gauge?
Okay, so this is a 2 millimeter gouge. 1.5 millimeter gouge, sorry. Can you see the gouge?
Yeah, there's a question.
See this. Sorry. I want to make. Deepak had asked about the chorda, the bone around the chorda. See, his first stroke was at the junction of the chorda and the bone.
Yeah.
And now he's going superiorly. Yeah.
Correct. The idea is to create a fracture line. It's like scoring a piece of glass.
Ashish.
Yeah.
Can you tell again how to protect the chorda?
Sorry, you're asking me or Ashim?
Yeah, anybody. During this step of hammering,
yeah.
protect the
So
chorda.
first, if there is too much of a bone over the chorda, you have to curate it out of.
Which I have done. I've done exactly that.
Then you take a micro fracture around the chorda so that the big chunk of bone does not get entangled, like it gets fished into the chorda. That was what Deepak was pointing out.
This is an important step.
So that is exactly what I had done. You saw. Initially, I curated around this area, then I removed the mucosa, and now you can see that with a couple of hammer shots, you got a very good exposure. You're getting a very good exposure.
Learning this technique, no, Satish, I find it in those very thin pockets that form in the posterior superior. You know, if you use the drill, you sort of break into the pocket, the epithelial pockets that we see. This technique of removing the bone without damaging the epithelium in those cases, not of otosclerosis, I find it very, very useful.
Yeah, you will see that maybe in the next case of cholesteatoma that I'm proposing to do, curate.
Yeah. And
Ashim,
this, honestly, in every tympanoplasty case, one can practice this overhang removal of some degree, so you develop your tactile feel.
Ashim,
Yeah.
tell me how to control, how to prevent overdoing, over removal of the bone. How do you control?
See, you have to see where is the uh, overhang, for example. Now, in this case, the overhang was such that I was not able to see any part of the ossicular chain.
Thank you, buddy. Thank you so much. Thank you.
Because every time I see you, removal of the
Now,
bone.
the issue here is that you have to make sure that you do not see too much of the incus. The long process should be seen. It's blocked.
See, we can see the fallopian canal.
The fallopian canal is there. It appears to be dehiscent.
How to get this gouge?
Okay, so now you must see
Yeah.
the base of the pyramidal process.
People are wanting where to get this gouge from.
Boss, it's custom made. I can send them one, whoever wants.
How many people you will send?
No, it's available with Kalelkar.
No, the Kalelkar gouges are terrible. Long curd.
Really?
I have the privilege of being gifted by the big man ABR and then Ashim. There used to be a surgical company called Hegde. I don't know whether they still.
No, unfortunately, the gentleman is dead.
Oh, okay.
I am so
So you see,
fortunate.
this is the chorda is still stuck in its canal.
Yes.
I'm gently elevating it out, curate. Some people may feel that this exposure is adequate. I feel it's still inadequate.
Ashim,
Yeah.
2 points. 2 points at this point of time. One is what is your superior limit of exposure? Number one. Number two, how do you extend anteriorly if you need to, cut the anterior malleolar ligament?
Okay, so I will show you that very quickly here.
Did you, sorry to point out, did you just see the stroke that it did, which exposed the pyramidal process?
It's very important to see the processus pyramidalis because you need to see the base of the posterior crus.
Yeah. Now, what is your limit to the superior exposure?
Okay, I will show you. One moment, please. See, what I've kept is a piece of gel foam, so all the curated and fragments of bone will adhere to that gel foam and they'll come out. Now, I don't know if you can see properly, but long curve, please.
How the screen say?
Whatever is different, we'll show it.
Yes. Now,
You see, this piece of gel foam,
yeah.
I will just remove it and we will then
So
reveal
please
the...
send back the picture. The picture is going.
Okay.
Yeah, fine.
Ashim, how do you extend towards, anterior malleolar ligament exposure?
See, what happens is that when you are doing your 12 and 6 o'clock incision,
Boss,
one second.
at this point of time, can you reduce the magnification a little bit?
yeah, I'll do that. One sec.
And show us the anterior exposure. Now it is perfect.
Okay, so now you can see that this is the malleus. Okay, this is a lateral process. This would be your extent of elevation from
Yes.
12 o'clock, all right?
Yes.
Now I need to see the anterior malleolar ligament. Give me 1 second, right there.
Show us today.
So I just extend this. Give me a circular knife.
Cut it for us today, whether required or not. It is not going to harm.
See,
I
the
hope-
idea is that you want to do it. I told you clip this down. The idea is that you have to make sure that you are able to see it if you want to. So can you see? I'm going up to 2 o'clock.
You go more anteriorly like this.
Exactly. So I'm going up to 2 o'clock. If necessary, I'll take away part of the canal.
Yeah.
Because I want very good exposure before I start my work on the foot plate. Because
Ashim,
after
so
everything, if I find I need to do it, then a lot of oozing happens.
boss,
Yeah.
so many people are asking, they're sending requests to show the anterior malleolar ligament.
I'm sorry?
So many people are sending requests to see the anterior malleolar ligament.
Yeah, I will show you. I will show you by and by.
And cut for us today.
See, I'm moving forward more and more.
Super.
Can you see here?
Yes.
I did it. So I have reached the level. I will not expose it further until I need to, okay?
See everyone with the ease he has reached far anterior superiorly by the transmeatal exposure. What an exposure was centralized.
Yeah, one sec.
Amazing. Amazing exposure.
Thank you, sir. Coming from you, brother, I will take that as a supreme compliment. I find you probably the best general ENT surgeon on the planet.
Come on.
Super, ultimate. I mean, whether it is a neck, whether it is a ear, whether it is a throat, you are the ultimate. So if you have something good to say, for me, it's a huge, supreme compliment.
No,
Centralized,
it's amazing. Centralized. Was one more question.
Yeah.
When you cut the superior anterior malleolar ligament, first of all, how to expose the ligament per se, and then when you cut, how to protect the chorda.
Yes. Can you see now I have reached the annulus anterior to the head of the malleus?
Yes, yes, very clear.
Now I will just stop my elevation here and put a piece of gel foam here.
इसका है नेक ही हिलता नहीं
छोड़ो, छोड़ो, छोड़ो।
कैसा करेंगे दिखाएंगे भी कैसा
Now let us go back to the area of interest,
It's difficult है
the
मतलब
foot plate.
They want to see
how
anterior.
will we demonstrate
You will come back. So you will come back after some time to the same area to show us.
Yes, I will, right at the end. I don't need to cut it till the end.
Okay, tell us how to ascertain the mobility, how to ascertain the need
तिथे
of
घेऊन बघितला
malleolar ligament experience.
Okay, now first, we have to first ascertain the mobility of the whole ossicular chain, okay?
Okay, can you show how to do?
So now I'm going to go high magnification. Okay, long
Yes,
curved.
but it is going off center. Yes, yes, now.
One moment.
याचं टेम्पलेट कुठे आहे
Yes.
So the first step is to touch the neck of the
Close
malleus.
out of center,
त्याला इन्फिल्ट्रेट करा आणि आपण सुरू करूया
out of focus. Yes. Yeah.
Can you see the neck?
दे 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 जो- जो भी है
Can you see
Yes,
the
now,
neck?
now. Very good.
See the movement.
So lateral movement of the malleus.
no big
Now that is first one. The lateral movement is good.
So you are placing your needle underneath the neck of malleus.
Yes, under the neck. Never under the handle, under the neck.
Okay, and then
The next is trying to move the incus. So can you see the joint move? Observe
Yes.
the joint,
Yes.
okay?
Very
IS joint.
yes,
See the joint.
yes, yes, very clear.
Team, do the suction of the blood on the canal. It will look better.
And then show us the foot plate level.
Yeah, one sec. Blocked. We need a vein, huh? This is too big. Give me a small one. Okay, so we have a decent facial nerve for sure.
Yeah.
Yeah, it little bit of the bulge of the facial nerve means decent.
Okay, so this is a blue foot plate.
But nice thin blue foot plate, yeah.
Yes.
So I am a little luckier than you, Ashish, but I like Ashish had. You can see the posterior crust is wedged and locked onto the promontory.
Promontory, yeah.
Yes.
Okay, so now I can see the base of the posterior crust, okay?
Yes, very clear.
So now I'm going to start drilling. Now, when I want to drill, I drill from posterior to anterior. I have purposely not using a luminous laser.
Can you repeat? Your first step is thinning the posterior crust.
My first step will be to drill a little bit of the pyramid because I cannot see the base of the posterior crust.
Okay.
If I can see the base of the posterior crust, I won't drill the pyramid, but in this case, I am not seeing it.
Okay. Any region or when would you use the laser?
I would use a laser, but most people don't have the laser, so I'm not using the laser today.
Great.
But see, this drilling of the pyramidal process, one should not be shy or scared of. This is very important during managing tympanosclerosis, not so much in autosclerosis, but when you want a good clearance. Yeah, this is beautiful.
Ashish, you are ready with your presentation after this?
I am ready, but we are also induced successfully. The difficult intubation has been managed well by Gayatri.
But after this, your presentation is ready?
My present is ready, yeah.
Okay, okay, great.
So now what I'm going to do
But I was
is
wondering, okay, because then I want to also harvest the rib, na Satish?
drill the base of the posterior crus. Maybe Ashish, it's a better
around.
idea for you to give your presentation after the pinna.
No, 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 no.
Okay.
Okay, what
So
about the boss
Satish, if
says?
I make the presentation, then what is after my presentation?
Yeah, we'll do something. Last year we'll do something, and then
Okay.
meantime you harvest. Why don't you harvest now?
I'm doing, but this I will finish. No, I'm starting actually. I'm starting meaning we're doing the printing draping.
So this is thinning the posterior crus, is it?
Yes, I'm
So-
drilling off the posterior crus. In this case, it's a blue foot plate, so I will do a vein interposition, okay?
See, this one step for everyone who is watching,
Number 2.
this one step of thinning the posterior crus can make the surgeon's life so easy.
Yeah.
It improves the exposure of the entire foot plate like anything.
So
So
now
for,
the
for
capsule,
Satish, for
this is
Ashim,
the
this drilling
capsule.
is because he has to flush the posterior crus and the foot plate. His vein has to be flat.
Now the vein has to
So he
lie
cannot-
flat.
Yeah, that is why and his drilling was exactly in the opposite direction of mine. He drilled posterior to anterior. I go from anterior of the posterior crus and come backwards.
Okay, now in this case, you can see that the stapedial
Stapedius
tendon
can
is
be preserved.
parked lower than the incudostapedial joint. So I'm not going to be in a position to preserve it. So the next step I'm going to do is cut the stapedial tendon. Scissors. Scissors. Micro. So standard micro scissors, just cutting the stapedius.
Ashim,
Yeah.
I'll take 1 minute.
Yeah.
I can see on the screen a very, very senior otologist with us. Let me welcome Dr. Jagdish Nayak from Muscat.
Welcome, sir.
He's a dedicated otologist. I know him. He has been in practicing in Muscat for more than almost now 30 years.
Wow.
He's a dedicated otologist. I have seen him. I've been there a couple of times. He's an amazing, otologist. And their team, we have seen his another senior team member, Dr. Subirendra Kumar, last time in his otology team. And we
Thank you. Thank you, Dr. Satish.
Welcome,
Thank
sir.
you,
Welcome.
sir.
Very welcome to you.
Excellent exposure, Dr. Ashim.
Thank
Your
you, sir.
comments are most valuable. Sir, most welcome.
Okay, now, Satish.
I've just joined now.
Yeah, welcome, sir. It's a bilateral otosclerosis. High
Yeah, I
frequency SN
want to
loss.
ask you.
Yes,
I
sir.
want to ask you. This posterior crus drilling you do in each and every case? or only
Whenever
when
I
it
want to
takes-
use a vein, yes, because I need a flat surface.
Ashim, just a moment, stop here. See
Okay.
the exposure of the foot plate, sir, after the posterior crus drilling.
Yeah,
Entire foot plate is fully exposed. You can see
yeah.
this single step of posterior crus drilling has changed the entire scenario. See the exposure level now.
Okay. Satish,
Yeah.
boss, I want to show you my slightly different technique of breaking the anterior crus, okay?
Please, please.
Now, what happens is that when you look into the physics of the whole story, always the least force is exerted around the axis about the structure that you want to break.
Yes.
So, what I'm doing is I'm twisting. Can you see
at
I'm
this point of
twisting
time-
it around the axis
Boss, why do you want to do at this point of time?
because I want to make a 0.8 millimeter hole.
So where the anterior crus is coming in the way?
It's not a matter of anterior crus. I want the whole superstructure out.
And in case you happen to mobilize the foot
It
plate,
will not
then-
mobilize, sir. It will not mobilize.
at this point, why don't you want to use a laser if you have?
I would, but I want to demonstrate for most people who don't have a laser.
Okay.
So this is for the, I have a CO2.
Yes, that's why.
You saw how I was able to easily break the posterior crust with complete safety?
Yeah. Yeah, can you show again? Can you explain again?
Is in Nova.
See, this is the turn. You're twisting it.
Okay.
And now there your superstructure is out.
Okay. You're not pulling laterally, you're just twisting.
Twisting it. You never push laterally.
And since it is fragile, it breaks easily.
Even if it is relatively thick, it won't. It will definitely break easily.
जरा टाय करा त्याला कारण मला ते ड्रिलिंग करताना त्याचं डोकं मला सॉरी.
Now we can see the footplate exposure.
Footplate exposure is complete.
Yes. Now for the audience, Dr. Ashim Desai is going to show you his technique of vein graft use.
Yes,
Sealing of fenestra with the vein graft. So Ashim,
Yeah.
for vein graft, when you use the vein graft, what additionally you need to do about removal of the mucosa or anything?
Yes, I will demucosify the surface of the footplate.
Footplate and?
No, that's it. Just the footplate and a little bit surrounding. Can you see? This is a otosclerotic focus on the promontory.
Yes, yes.
So I'm
So
going
he
to remove
he needs the crura remnants not to be attached to the footplate. So he needs to, one is the mucosa has to go because he doesn't want to bury the mucosa under the vein. And two is the crura has to be completely flushed, drilled and flushed to the footplate.
Yeah.
Two prerequisites.
So that makes the things complicated sometimes. Sometimes you have ridges on the footplate that you need to flush completely.
Absolutely, yeah. And the width of the fenestra should be minimum. If it's a very narrow footplate, then he can't
If it's
fit
a
his
narrow
vein in
footplate,
there.
you cannot do it.
Yes. And secondly, this demucosalization sometimes leads to bleeding as well. You need
I would
to.
rather bleed first. See, if I had a laser, I would have burnt it.
Yes, I know.
But if I would rather let it bleed first, can you see?
Before the fenestra is made.
Before the fenestration.
Many
Let it
people
bleed as
want
much
to
as
know,
the water. So give me a very small adrenaline injection.
like, how to harvest vein graft. Many people are asking.
I will
Yeah,
show.
he will
I will show.
finish.
That's why, I am very fortunate to have with me a junior colleague of mine, Dr. Priyank Talati. He's a very dynamic young guy. And, those of you know me will relate to him. He knows a little bit of everything on this planet. So I'm very fortunate to have him with me. And I'll take this opportunity to introduce my team. Very old, very venerable team. I have Rashmi, both Ashish and Satish know Rashmi. She's been with me since I started my practice. Dr.
Rashmi is an
Sonal.
asset for you.
Rashmi, say hi to Rashmi. Camera here. Okay, so she's she's Rashmi. She knows as much of otology as I do probably. This is Dr. Sonal here. Sonal's our anesthetist for the last 20 years. How
I
long?
know. Amazing.
It's amazing. I mean, Satish has done cases with me. All sorts of cases have been done without any let or hindrance. Sunil has been here with me for the last 20 years. Well, 25 years actually. So it's a
See,
very
even
old and
people,
venerable team. And this is Dr. Priyank Talati. He is up and coming ENT surgeon. He is an awesome guy as a person as well as a focused guy. Very, very fortunate to have all of these guys. So I'm delighted to have them as part of my team.
Thank you, sir.
So
Sir,
the next step now what I have done is I have scraped the mucosa on the promontory. I have put a piece of adrenaline gel foam to decongest the mucosa on the promontory. And now I'm going to go and harvest the vein. Vein, please.
Yes.
I will need external camera on the vein. I need light here.
So have you demucosalized the footplate surface as well?
Yes, yes. You saw me do it.
Okay, done. So after that, you have put a gel foam,
Yeah.
control or for the hemostasis, you can
To
say.
control the chota mota oozing, capillary oozing, and all that we are likely to
And
find.
now you are going to the vein graft harvesting.
That is right. Right.
From the wrist?
From the dorsum of the wrist.
Okay. Can you show?
Yes, of course. I don't know. I'm trying to get the external camera going here.
Can you show with the microscope?
Now we are getting the picture.
Yeah, it is good. It is good.
Can you see something?
Yeah, we can see.
Okay.
And also, Ashish sir, people want to see each and every step of microtia surgery. So please don't start. People want to see each and every step.
I'm
See,
going to cover most of it in the lecture.
Okay.
So don't worry, we have to also manage more cases. So I will tell every small detail. Don't worry at all.
yeah, Udbhav, he'll explain every point what he is doing.
So the rib harvesting, unfortunately can't be demonstrated.
There is no need, because rib harvesting is a standard procedure.
Standard,
required
yeah,
for-
just like the rhinoplasty guys and anyway.
Yes, when we do rhinoplasty or many other purpose, we need rib.
So now
So
I'm
he's
injecting on
harvesting
both
the
sides of the
vein
vein.
from the dorsum of the wrist. The another side you can harvest from is the superficial temporal vein in the same field. We do harvest sometimes from the superficial temporal vein.
Yes, but I can't see anything. I need you to hold this.
So infiltrate a little bit, harvest a
Just-
segment of vein, say centimeter or so.
Around 1 centimeter is all that's required to be harvested.
Yes. See, that's a horizontal incision.
Yes.
Then he'll open up vertically. See this?
You can see the vein deep down. I don't know if it's visible.
हाँ सतीश बोल.
Can you see I have a nice piece of vein here?
Yes, sir. Yes. Wonderful.
Priyank,
Beautiful, sir.
suture this.
Sir,
So
is
now
there?
there is a couple of points.
Yes, sir.
The most important thing is that you are not going to touch the vein with your hands, with your gloves.
Okay.
And I am going to ensure that this is now, you see, remember there is some xylocaine adrenaline on this.
Yes.
Alright?
Yes.
So what happens is that I need to wash it off. So the next step is that I'm going to put it in saline.
Okay. Okay.
There is no, you are not supposed to use any gauze while you're harvesting the vein. You're not supposed to mop. So you have to make sure your injection is precise, everything is precise.
Yeah, you are not supposed to contaminate with any foreign body,
Absolutely.
because
absolutely.
this is going to be placed on the vestibule.
That
Sir,
is
what? Yeah.
jar tip. That is a very important part. You cannot afford any form of contamination whatsoever.
Sir, people are asking what are the other places from where we can harvest this vein?
Superficial
Superficial
temporal vein, as
temporal
Sati
vein.
said, you can harvest it from the ventral part of the wrist. You can take it from the leg, medium,
Okay.
from the foot. It doesn't matter. You want a vein. That's all you want. Okay.
Yes.
So now the oozing also has come down a bit. Tip.
Any special precautions when you have a decent facial now at this point?
Yeah, you have to make sure if it's a very narrow niche, you don't fool around too much with it. As simple as that.
Suppose you don't have a decent facial now. Do you demucosalize the facial canal as well?
No, never. Because then there are sometimes very large vessels on them,
Yes.
and when you try to demucosalize, they start oozing, and you can't do anything about it.
What are you doing exactly?
Okay, now I'm just widening. There's a little bit of otosclerotic focus on the promontory. You can see that yellowish focus.
Yes.
I'm just going to drill it out a little bit and flattening the last bit of the posterior crust.
Okay.
So now, there's going to be a lot of discussion whether to use a vein or not to use a vein. According to me, it's a philosophic decision. If this was your year, what would you want?
Ashim,
Yeah.
would you use the vein in the last case which Ashish did?
No. Yes, actually I would.
इतना के बाद देखते हैं.
Because
After
only the
so much of
anterior
drilling?
thick focus was there, dry jab. I could have used a vein in that one. It had a good access and only an anterior focus was extremely thick and vascular, as you saw.
Yeah.
I want to narrate a very interesting story about a Dyson facial now.
Yeah.
2 cases I've had. I used to take the drill inside, that same drill that you saw, and the patient used to get facial twitches. This was under local anesthesia. I was doing this case. First time it happened, I'm not even touching it. The burr is just going past the long process of incus and tuck, 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 it starts. First time it happened, I got scared. I closed the patient. It happened the second time. There was actually a electrical short circuit. There was a current flowing through the handpiece of my this thing.
Awesome.
And that was enough for the diaphragm facial nerve to get stimulated.
Oh.
So there was a short, like the earthing problem was there with the micromotor.
Amazing exposure, Ashim. Amazing.
Yeah.
Thank you. You saw that little bit of drilling, how it made a difference?
The best thing is, the beauty is, the foot plate is completely exposed, completely flush to the surface. There is no undue, elevation, depression anywhere. Absolutely flat.
Is it a relatively short, long process, Ashim?
Slightly, but I don't see a problem in the perpendicularity. So I'm using a measuring gauge, and I'm seeing that around 425 is the length that I will like.
So this was the measuring gauge which he uses.
Between 4 and 425. Now remember, these are all the lengths are very relative to the manufacturer of the measuring gauge.
Yes, we should use the same measuring gauge which the piston belongs to, the same company.
Same company,
Yeah.
exactly.
And I think we
Which piston
forgot
are
to
you
ask
going to
Dr.
use?
Alamadi also the 6 millimeter he said. Probably we did not ask him the make of the piston that he uses.
What
Yes.
I'm
piston are you
sure
going to use, Ashim?
Sorry?
What piston are you going to use?
I am going to use a standard long curve Teflon piston made by our Indian company, so nothing fancy.
Indian Audio.
Indian Audio Center, Jindabad. I've done almost 5,000 cases with that.
Chandigarh.
Chandigarh. Out of
If he
6,000
uses
cases,
the
I've done
imported
5,000
version,
cases
his
out that.
patients
What
from
is it?
Surat will start speaking.
What are you doing now?
Now just a little bit more of
More
the
mucosa.
drill.
संतोष में दूसरा चश्मा
The same Indian Audio. Centralize.
One sec. I'm just removing the gel
हे
foam.
करतो काय रिप्स काढायला सुरुवात करतो
So in the first part of the session today, we are going to be through the 3 cases of,
3 otosclerosis, 3 different techniques, and all with the same result, provided you follow the fundamental principles
yes.
of measuring the length, of making sure that there is no suction on the oval window, so on and so forth. Drill.
आता मेरी
Biggest reason of the post-operative problems is suctioning over the oval window. बहुत centralized.
Okay.
Yeah. तुला काय प्रश्न आले तर मी उत्तर देईन, डोंट वरी. In fact, I'll make enough noise.
Hello.
Yes, Udbhav.
Sir, Dr. Grish wants to know if a patient with otosclerosis is having complaint of tinnitus. How do you counsel him before?
You tell him that we can't guarantee the tinnitus, but when the relative hearing moves up, the volume of tinnitus will move down.
Yeah, Udbhav.
Yes.
Majority
So
of the
now
low
can you see I'm just through.
Oh,
अरे क्या हुआ?
it's a light
इधर
and
गया.
it's not
0.4
matching.
disc. Now I have a set of measuring discs.
हाँ.
हे बरोबर नाही लागलंय.
अरे वीरू को बुलाना.
Satish.
Yes, sir, you are audible.
Okay,
What
so now
direction?
these are measuring discs.
बरोबर आहे.
I am measuring the diameter of the foot plate.
Okay, sir.
What size is this now?
Now this is a 0.4 disc,
Okay.
and I also use it to remove the bone dust.
लोकांपासून सांभाळून राहा. एक्सपोजू नको
Yeah.
लोकांना.
0.6.
Exactly.
कुठे होता त्याचा?
You can see I am staying very far from the hole in the foot plate. And this is a 0.6 disc.
Light lens.
Nice. Going very smoothly, sir.
Can you see that? So we are very sure of the diameter, you know.
Okay.
It's a very important part.
Wonderfully going in and out without touching anything.
Drill. Now I can see that edges of the foot plate are not exactly round. I need to widen slightly.
Okay.
So very, very, very slowly, extremely slowly, I will use the drill to widen the hole.
So what is the speed for the drill now?
Less than 800 RPM.
Okay.
You saw how slowly we did it?
Yes, sir. Yes, sir.
0.4 disc. A little bit of bone dust out there. I will go ahead and remove it.
हाँ केस तो देख रहा था अच्छा this is another thing which I forgot to mention. He removed the bits of the foot plate that were dangling inside because he does not have a mucosa which holds them. We do not demucosify, so the mucosa actually holds them, so they don't become free floating particles in the vestibule.
It's not a matter of free floating, Ashish. My problem is, give me a pistol.
Yeah, with your vein there.
My problem is that the vein, they will sort of stick to the undersurface of the vein and create ossification.
Yeah. Now, I was trying to make a point that when you use the vein, you are obliged to remove them.
Yeah. So it's technically
okay
slightly more atpata.
Yeah.
Hello.
Yeah. So this is 425, okay? This 4.4 and 1/4. This is a Richards cutting jig, ideal for Teflon piston.
करूँ का incision क्यों ना?
Now I will measure this in position. So what I have done, I have measured the diameter of the fenestra. I have measured the length of the piston. So measure.
काढल्यानंतर तो ऐकत नाही ना, तो बोलतो हे संपल्यावर you give the talk. So
you have to keep measuring, my friends.
Ashim will. I think so.
Ashish, you need to carry on. Please go ahead. Huh?
Don't चलता इधर क्या
Hello. Ashim.
Yeah.
What size fenestra is exactly?
Can't hear you.
What size the fenestra is?
0.7 millimeters.
And your piston size?
425, but I'm not final on it yet.
No, piston diameter.
0.4.
माझा मायक्रोफोन बरोबर आहे बाहेर
Medium.
The best thing is the exposure of the whole window. Complete exposure.
हे
You see this? Now I will do what is known as a hanging and bending test.
So you do all these things before placing the vein graft.
Yes, the measuring is done before placing the vein graft.
तिकडे कसं वगैरे
So what is the hanging test? You pull it outwards and it should anchor on the edge of the foot plate.
long inside.
There, you saw that?
Yes, sir. Yes.
Beautifully anchored. And now you put it back in and push it against the edge of the foot plate.
Yes.
It's not jumping out. So it is perfectly measured. So this is the right length, practically measured. This is a practical measurement.
See, the hanging and bending tells you whether the piston is short or overlong.
Correct. Absolutely right, sir. Don't move, please. Don't move.
So the piston size is adequate for this?
Absolutely, because you saw the hanging test and the bending test.
Yes. Now the entire area is so receptive for the vein graft.
Yes.
See, all around the fenestra is completely raw, very well exposed. It's not like a deep well.
Dry.
What an amazing exposure.
Boss, thank you. But I'm lucky, the exposure was good. My YouTube videos are bad exposure. I don't know if you've seen it.
Okay, can you tell the contraindication when you don't use the vein graft?
Obliterative focus, too narrow a foot plate. See, whatever excess fluids and all, I'm using it with a dry gel foam. I'm not putting suction anywhere close to my fenestra.
That is a message for everyone.
Very
Never
strict
to
message.
use over the fenestra. See, his vestibule is full of perilymph. He is not even anywhere close to the vestibule to bring his section close to.
See, boss, 0.8 millimeter.
Satish, what is the amount of perilymph in the vestibule?
That Satish will know more than me, but I believe it is 0.2 microliters or something like that.
Oh, it is 70 microliter. See, this was the measuring gauge, measuring the size of the fenestra. And I'm so fortunate to have this gift from Dr. Ashim Desai long back.
Which you never use because you got a perfect laser.
I do use sometime.
Yeah, when
And
you
this
don't have
is the
laser,
only-
you can use that.
This is the only tool by means of which you can exactly measure the size of fenestra.
Okay, so now what have I done?
Can you show in a, yes. See,
Forceps.
this is the vein graft, the intima is inside, this is outside, which is he has cleaned up. This is the adventitia outside.
It's the side is very, very important. Clean.
How do you decide the side?
Intima should face the surgeon
Yes.
and
A smooth
adventitia should
surface.
face the labyrinth, not the
Yes.
other way around.
Yes, he has made the surface of the footplate raw, wherein the raw surface is going to sit. That is outside. And this intima, which is a smooth surface, is going to face the surgeon laterally, so that it doesn't make any adhesions with anything, any structures laterally.
Because it's very important to prevent the vein has to lie flat. It's very important to prevent any form of adhesions.
Yes, see what he is doing gently and gently, stripping off the excess tissue. He is removing the excess tissue, only the vein wall is left behind.
You see, what happened is what you saw, which was slightly narrow. I mean, you felt the lumen of the vein was narrow was because of the adrenaline. Now you can see that this is adequate.
Yes. Super.
Scissors.
Now you're going to cut it?
Yes, sir.
See now.
See, there's a junction here.
Center. Yes. So it's opened up. And see the intima.
That is the most important part. The adventitia should face the surgeon. I mean, intima should face the surgeon.
Yes. Yes, opened up. So the tube is opened up and this is intima. You allow it to dry or use as a wet or roll in
Wet,
some.
boss, wet. You will be happy to know that I use wet.
So will you roll in something to introduce?
I will show you how I do it. Give me 1 minute.
Yes.
Give me a measure. So now I measure this also. I need around 4.5 by 4.5. So this is all 4.5 by 4.5, approximately 15.
Yes. So this is always fixed or what?
Generally, general rule of thumb.
Because the fenestra size is 8.8, no? So that is a fixed size.
Ashmi not cutting. Hari Om. I don't care. It's not cutting. The blade is bad. Okay, so now 15. Measurement. Let's measure it once again.
Superb. A treat to watch.
Thank you, boss. Measure. Okay, so now it's around 475, 4.5 approximately. By around the same.
See the thin vein.
Precision. Precision is very important here.
Any extra tissue, and it has been studied earlier a lot of times. Do you know the elasticity of this vein is comparable to the elasticity of the natural annular ligament of the foot plate?
Yes.
Closest to the natural annular ligament.
Yes.
That's why vein is the preferred tissue.
And not fascia, because fascia can cause adhesions.
Yes. Contracture.
No. Adhesion to the long process, lenticular process, so on and so forth.
Yeah, because it is, raw on both sides.
Yeah, it becomes dangerous.
Yes.
Okay.
What about perichondrium then? Same.
Perichondrium is too thick, my friend.
लेक्चर तोपर्यंत याचं सुचरिंग करून टाक.
Boss, we want to see how you introduce.
Yes, just now, remember I had put that little piece of gel foam. I'm taking it out now to protect the oval window.
Okay.
All right, so that's your fenestra.
Super.
Okay.
What a view.
Vein. Now you have to be under slightly lower magnification, gel foam.
The best thing is the vestibule full of parallels.
I will take.
तसं कसं असेल.
Dr. Ashim,
One moment. So now I'm introducing the vein. It's wrapped on a piece of gel foam.
Ashim,
Yeah.
11,000 people watching your magic.
Wow. It's
Right
your
now.
magic, brother. It's your magic.
13,000. It's amazing.
So you saw how the vein is in position?
Yes, sir. So simple. You made it so simple.
Very good. Now I will remove the gel foam, which I have used. It's like a little potli.
Yes. So roll in the gel foam.
Rashmi is blocked, please. I'm sorry, it's a little blocked, the suction. Usual story with suctions around the world.
What size suction are you using?
26.
संतोष कमी कर.
26. Imagine.
Very narrow.
नाही 18 कर.
This is a very, very important step. And see how gently is unrolling the vein.
Can you see how the vein is unrolled?
Amazing. And I can see through the vein the site of fenestra.
Yes, boss.
दिखा रहे हो कौन सी टेक्निक
Yeah, Ashim. Superb, superb. Dr. Ashim,
Yeah.
are you using foot pedal suction?
No.
So how much is the power pressure of the suction now?
I can't see actually. It's on that little gauge which is a little bit far away, but it's not a very high pressure medium.
Ashim centralized. See the amazing way he unrolled the vein. The vein is beyond the margins of the oval window all around. That's why he chose to use the size of 4.75 by 4.75 millimeter.
What?
Beyond the margins of oval window. The vein is going over the facial now, over the promontory, anteriorly and posteriorly beyond the oval window margins.
So this is about 10 to 12 millimeters of mercury.
Okay, okay, thank you.
Okay. So now this goes out.
Yes, super.
Barik again. And the piston will now go in.
मोठी आहे तर छोटी दाखव याची
See this?
भूक लगे
Ashim sir, please explain again what is the direction of intima medially, laterally, how you place the vein.
The intima faces the surgeon.
Okay, okay,
See, this
And
is
the adventitia faces the promontory.
okay.
Always, that is a sacred thing, so you have to be very careful not to change that order.
Yes.
The
See what-
surgeon has to be intimate with the vein. If
Absolutely.
it helps you remember.
Ultimate.
Trust
sir.
Ashish to come up with the perfect
Now,
statement.
now no one will forget this.
So, like when when you open up the vein, the intimal surface, you have to keep an eye all the time until you place over there. Because once it dries up, you cannot differentiate.
Medium. Yeah,
This
so
side-
we always use it wet, medium.
That's why he uses the wet. Once it dries up, you cannot make out which surface is what.
Long curved.
To me, the biggest advantage of the vein, besides the sealing the inner ear, is it prevents you from using an overlong piston. The reason is, the moment you try to use an overlong piston, your vein will be invaginated deep inside, and that will warn you that your piston is overlong. That is something can easily be prevented by using a vein graft. It warns you from using an overlong piston.
Number 5.
You know,
Ashim,
Yeah.
जास्त
we
वर आहे
would
का तुला
like to see your
just ह्याला थोडंसं काढायचं
crimping by using two hands.
Let us see if that's going to be feasible. Everything to be adjusted as per patient.
But boss, you have to adjust for the audience.
Yes, sir. It's like a showstopper.
Okay. All
Yes.
set?
All set.
Okay, now give me right, number 5. See
The
now,
crimping is one
see
step.
now, this
I
is one
really
very
hate.
important step. See how free it is.
Yes.
just एकदम
See
टाइट
how
आहे
free it is.
Can you show the lower end again? Can you little bit suck over there?
Yeah, 1 second. Give me a barik section. I'll go back to my number 26 section. That was a number 24. See how well it is sitting inside.
Ashim, there is a comment from somebody
Yeah.
that they've never heard of 26 number section. How do you get it?
We've been custom made for all of this. I mean, I'll be happy to share. But 26 is it's a beautiful size, you know. I mean, the tragedy is that it keeps getting blocked time and again.
Yes, it is so fine.
That is the
not a
Gould
good
section.
See,
Give me 4.
now see, he's using both hands to crimp the piston. That is something, a treat to watch.
So
It
what
is not
happens
always
here
easy.
is
See,
you're
both hands.
anchoring the lower
Yes,
end
sir.
here.
What centralized? He's using both hands. That
Yes,
is
sir.
something you will never get to see anywhere.
So you can see how I'm locking the lower end down like that.
Yes, he's locking through one end and now using the other end to crimp it
And then
at the
the
same place.
upper end is adapted like that. You see
Wonderful,
that?
sir.
Amazing.
You know
Ultimate.
why? The advantage of this.
See the so much of ease. Through the speculum, he is using two instruments through both hands. One to stabilize the piston and other is to crimp. What a technique.
Unbelievable, sir. Unbelievable.
Amazing.
And then I'm just doing a final tightening.
This step is something I really hate. Crimping. That's why I changed to titanium piston, which doesn't require crimping. That's the only reason.
So you need to have
now-
Ashim sir expertise. Then only.
Now, what I'm going to do is everything is in position, Jad.
See, this crimping is so wonderful. It is such a calculated step. By a human hand, it is so difficult otherwise. It should not be under crimping, otherwise a loose piston over the incus will
That
keep
will
on
surely
hitting the
cause
incus and
necrosis.
keep on hitting the incus and ultimately can erode the incus.
See, boss.
Similarly,
Can you
Yes.
see? Can you see how free it is? So I don't need to do anything with the anterior medial ligament.
Yes, yes.
amazing,
yes.
amazing.
Extremely free.
Similarly, a tight piston, if you try to, crimp it tightly, it can dislocate the malioinguinal joint and that's a disaster. So it should
Everything
be,
has to be just so. Stape is a very precise surgery.
we can see your hand movements, the kind of dexterity you have shown is amazing.
You have made it even more precise. Each.
Yeah.
Sorry?
Ashim, can you reduce the magnification a little bit?
Yeah, I'll just get out of the.
And for the audience,
Ah,
Dr. Ashim Desai is the one who always does the intraoperative audiometry after every case.
actually, we will be doing it in this case also, because all cases are done under local anesthesia. And the audiologist on table is my anesthetist, Dr. Sonal. She herself is a master of doing the audiology.
Wow, you're trained anesthetist.
Well,
She
she's
says
the
trained
anesthetist is a
Gayatri.
carver, Shilpakar. कैसे हो बहन? आवाज आती है?
Boss, how do you ascertain the need of anterior ligament resection? Can you show?
I'm sorry.
How do you ascertain the need of anterior malleolar ligament division?
After everything is put in position, if that freedom of movement is not there, what I showed you just now,
Yes.
then I would disarticulate, because what happens is that
And
you
how
cannot
would you
really
do? What
judge.
instrument would you use to cut the ligament?
I have a reverse angled sickle knife, a reverse sickle knife sharpened on the opposite end.
Okay, so you cut it coming laterally.
Yeah. And what happens is that you use that because you want to save the chorda, which is just deep to it.
Yes, just underneath that is chorda.
Just
That's
underneath
right.
is the chorda. So it's better to shred the fibers bit by bit rather than just go right through with one single movement.
Can you interpose a gel form and laserize it? Can you cut with a laser?
See, it's impossible to put a gel foam there, but what I do is I use a 4-watt laser, 4 or 5 watts, CO2.
Yeah.
And that works well. It just chars it and then you just divide it with your knife.
I think Ashish can do better with a KTP.
I suppose so. Absolutely.
But that's a contact laser.
Yeah, it's a
and
contact
very,
laser.
very precise wherever you want to use that in contact. So that is for the intra-op audiometry. He's using this, sleeve that is sterilized and where the microphone is going to go.
So this is a sterile sleeve, and this is it's covered. It's covering the cup. It's a single headphone. Now I will need silence here, so I'm going to go off air. So I'm going to mute you guys if you don't mind.
Oh, thank you. Thank you, boss. Superb. Amazing demonstration.
Wonderful, sir. Thanks a lot. Thanks a lot.
नाम बताओ.
Thank you. Ashish.